Welcome to AETCM, the emergency medicine channel. Shall I start?
Yeah.
A 58-year-old male patient, known case of aplastic anemia, brought to ED with complaints of generalized tiredness, palpitation, and dyspnea on exertion. Initial evaluation showed HP of 4.5 gram per DL, for which we arranged 2 units of PRBC, and first unit was transfused over 4 hours uneventfully. On second unit of transfusion, patient developed acute breathlessness and orthopnea with desaturation. And on examination, patient is anxious, tachypnic, airway is patent, breathing is saturation is 84% in room air, and respiratory rate is 34 per minute, with chest auscultation shows bilateral air entry decreased with bilateral basal crepitations. And on circulation, heart rate is around 110 per minute with BP of 150/100, and disability GCS is 15 by 15, pupil bilateral equal, and exposure patient is afebrile.
Okay.
And
so this patient was transfused 2 pints of PRBC
on second pint transfusion.
Okay. How was the rate at which you transfused the PRBC?
Second pint is at 2 to 4 ml per kg. Transfusion.
It was not given as a bolus dose, no?
Not as bolus dose, over 4 hours. Initially, first PRBC pint is at around 3 to 4 hours, and second on the same day.
Same day itself you have given.
Transfused. And since the patient is afebrile and the heart rate is tachycardia is there with the desaturation and tachypnea, and BP is around 150/100, and history of multiple transfusions, we suspected either transfusion associated cardiac overload or any we initially suspected that. TRALI also is a differential diagnosis since there is findings in the chest is bilateral crepitations and all, but more possibly in TRALI there will be hypotension. Here the patient BP is around 150/100. So initially we stopped the transfusion, and we started on NIV, and also we give one laxis bolus dose.
Laxis was given and post second PRBC transfusion.
Post second transfusion.
Okay. So you are suspecting a cardiac overload.
We took one ABG also at that point in room, which shows pH of 7.42 with PCO2 of 36 and PO2 of 55. Type 1 respiratory failure, and we also sent other workups like NT-proBNP sent, and other total counts and creatine, LFT, RFT levels, and also the LDH and all to rule out the hemolytic reactions and all. We took one chest X-ray which shows suggestive of pulmonary edema, and also took one ECG which shows sinus tachycardia. After initial evaluation, we suspected it as TACO, and we started on NIV, and laxis infusion was given.
So this was the symptoms. Patient was having any other symptoms, fever or?
Patient was afebrile at that point, and before transfusion also patient was afebrile. First transfusion was uneventful.
Okay. What are the many transfusion reactions are there actually? Can you what are the DDs for the same right now? You have been can be either TACO or TRALI, Some other reactions are also there. Can you explain?
According to the severity of the transfusion reactions, we can divide into febrile non-hemolytic reactions and hemolytic reactions, and also it can be early or late reactions will be there, and also there will be transfusion associated cardiac overload and transfusion related lung injury, and also there will be graft versus host reactions, and also allergic reactions will be there. Allergic reactions are simple allergic or anaphylaxis. So in case of febrile non-hemolytic reactions, there will be fever with chills, that most probably either during the transfusion or within the 4 hours of transfusion, and mostly seen in case of multiple transfusions, multiparous woman or multiple transfusions patients. In febrile reactions, there will be combination of recipient antibody against the donor leukocytes, and because of the release of the cytokines during storage. So what we do in case of mild, the patient presentation will be like urticaria and all. We will stop transfusion for some time, and we can give diphenhydramine, and if the allergic reaction subside, we can restart the transfusion. We have to inform the blood bank regarding this mild allergic reaction. But in case of anaphylaxis, we have to give the patient adrenaline and other steroids and all with the H2 blockers, bronchodilators. First, we have to stop the transfusion and give these all things. We can't restart the transfusion with the same PRBC unit, we have to cross match again, and we can arrange other PRBC to transfuse if the patient is in need of PRBC transfusion. That is in the case of febrile and allergic reactions. In case of febrile reactions, we can next time we can give leukocyte reduced blood products. In case of allergic reactions, we can give washed RBCs in the next time. And the other reactions are like the patient can also can produce have this acute hemolytic intravascular hemolytic reactions and extravascular hemolytic reactions. Intravascular reactions, patient present with fever, with chills, with back pain, flushing, dyspnea, and tachycardia can present with a shock due to hemolysis, hemoglobinuria and all. And also there will be evidence of new or worsening of the renal failure. In that case also, we have to immediately stop the transfusion, and we have to hydrate the patient to avoid the renal dysfunction. And also we can, if the patient is in shock, we can treat with IV fluids and also with vasopressors if needed. In case of IV hemolytic reaction, there will be reaction between the recipient antibody and that induce the hemolysis of the donor RBCs. And mostly it happens due to AB incompatibility because of the technical errors or because of the patient identification and all. In case of delayed extravascular hemolytic reaction, that most probably happened because of the amnestic response to the transfused RBC. That will happen in the extravascular sites, like most commonly in spleen. That case also we have to stop the transfusion. Most of the reactions we have to stop the reaction, and we have to inform the blood bank.
Which is the conditions where we are not stopping the transfusion?
In case of febrile, simple febrile reactions, we can treat that febrile event. In that case, we have to stop, but we can restart that. And also in case of delayed graft versus host.
Delayed reaction,
delayed reactions, and
we are not
stopping. Already the transfusion is
complete. With patient is on transfusion and patient is complaining of some itching. Will you stop the reaction, stop the transfusion, or continue the transfusion? What is?
If there is itching, better to stop the reaction. I'll stop the transfusion and wait for some time and treat the itching and all, and we can restart once the patient is settled. And also in case of if it is simple febrile reaction, mostly the temperature will rise by 1 degree or 1 degree. But in other febrile hemolytic reactions and all, it will be more than 2 degrees. It is not always like that, but it is a clue to diagnose.
So how do you differentiate between febrile hemolytic reaction and febrile non-hemolytic reactions? Both will be there now. Both will be having the same symptoms. Both will be febrile. How do you?
In hemolysis, there will be hypotension. And also we can send the lab investigations like
will be showing, but that will take time. Initial hemolytic will have hypotension. Okay.
In case of TACO, there is a definition that according to the Biovigilance Network, definitive TACO is no onset or exacerbation of 3 or more of the following within 12 hours of end of a transfusion without other explanation, like acute or worsening of the respiratory distress, and we can see the evidence of pulmonary edema in the chest X-ray. That means the evidence of the cardiovascular overload, and we can also see elevated BNP or NT-proBNP and other unexplained cardiovascular changes like elevated central pressures and all. In case of and they also defined it as probable TACO and also possible TACO. Probable TACO means these all findings with transfusion likely contributing, but individually other fluids as well as other cardiac disorders are not there. In possible TACO, as the findings with the pre-existing cardiac disease is there, then possible TACO can be told. Like risk factors are pre-existing cardiac or kidney dysfunction in case of extremities of age less than 3 years and more than 60 years, female sex, small stature and hypoalbuminemia, history of chronic pulmonary edema, and how much volume is transfused also is a risk factor, and rate of administration. If there is a previous history of TACO or the patient is in cardiac dysfunction or kidney dysfunction and all, we have to reduce the flow rate into 1 ml per kg. And the patient usually presented with respiratory distress, and there will be hypertension, tachycardia and wide pulse pressure, jugular venous distension and all. So that one differential diagnosis is TRALI, that is of transfusion reaction caused by the immune mediators such as anti-leukocyte antibodies.
How to differentiate TACO from TRALI?
TRALI also we can see hypotension. In case of TACO there will be hypertension, and the X-ray will be suggestive of pulmonary edema, more like a pulmonary edema. In TRALI there will be infiltrates, chest infiltrates. And the TACO will be developed usually less than 6 hours. TRALI will be within 6 to 12 hours. And the patient also presented with respiratory distress and hypoxia, and it's not associated with increase in NT-proBNP. In TACO, there will be increase in NT-proBNP. And treatment also, in case of TACO, we have to stop the transfusion, supplement the oxygen, and we have to mobilize the fluid by diuretics, and also we have to give assisted ventilation like NIV. And we have to report the transfusion medicine or blood bank. And to prevent the future reactions, we have to make proper recording and hemovigilance, and we have to inform the blood bank. And we can avoid this by unnecessary transfusions. We have to limit how much units per day, like 2 units per day. And rapid transfusion also have to be prevented, and reduce the volume of transfusion. Risk reduced by rate has to be reduced by 2 to 2.5 ml per kg to 1 to 1 ml per kg per hour, half the dose. And we can give pre-transfusion diuretics can be given, and we have to monitor the vitals.
So that's it regarding TRALI. What will be the treatment?
TRALI, we have to stop the infusion, and also we can give IVIG can be given.
Okay. Anything else you want to say?
And other reactions like there is also electrolyte imbalance in case of massive transfusions and all. That will be hypocalcemia and citrate toxicity, hypokalemia and hyperkalemia. In that case, if the patient is in normal hepatic function, then citrate can be changed into bicarbonate. So in case of massive transfusions and all, then hepatic metabolism get overwhelmed, and there will be hypocalcemia that will lead to excess bicarbonate, and alkalemia will be there, and potassium will shift into the cells, and there will be hypokalemia. But in case of stored bloods, there is chance for hyperkalemia also, because of in case of renal insufficiency and neonates. And infection possibility also have to be suspected in case of transfusion reactions. In that case, we have to stop the transfusion, and we have to do the blood cultures of both the donor and recipient.